Welcome to the Rapid Fire Early Career Lightning Talks. Each speaker has 3 minutes. I would like to remind you we are recording this session and there is no question and answer part of this session. However, you are able to write questions in the Q&A and maybe the speakers will have time to answer your question in that format. So if we kick off with Jill Harper, over to you.
Thank you. Good afternoon. My name is Jill Harper and thanks for the opportunity today to present on behalf of myself and my co-authors. Next slide, please. So, next slide again, sorry. Thanks. Address matching is a form of data linkage used to assign unique property reference numbers, or UPRNs, to addresses. UPRNs standardise addresses, enabling more efficient linkage. This builds on work done by Rogers et al. At the Steel Data Bank in Wales, who we continue to collaborate with under HDR UK. Next slide, please. So the objective of this research is to evaluate performance in terms of quality and bias of an open source address matching algorithm designed by the Discovery Programme using pseudonymised NHS patient addresses in a multi-ethnic population. Next, please. So our method was to run the algorithm consisting of 213 deterministic rules on patient addresses of a cross-section of 906,000 adults in the East London Discovery database. That is, patients with a current GP registration at practices in 4 CCGs in North East London as at July 2018. Next, please. So the characteristics of this population are shown on the screen, and these addresses were matched to Ordnance Survey's address-based premium database, which lists all UK addresses and their corresponding UPRNs. Next, please. So the results from this were first of all reported on, and quality assured using best practice reporting principles based on Guild guidance. So the algorithm was run in a gold standard data set, and the first best practice measure is that 99% of addresses were assigned the correct UPRN. Next, please. Further best practice measures are given in this table. So what these effectively mean is that only 0.1% of true matches were missed, and only 0.2% of matches made were incorrect. So overall, the algorithm is very accurate and balanced. Next, please. So next, we evaluated bias in the 1% of addresses that were not matched to UPRN using logistic regression and demographic characteristics. So this 1% were more likely to be from Black, Asian and minority ethnic backgrounds, except Bangladeshi, to be adolescents aged 15 to 19 or very elderly aged 19 over at the time of registration, to be men or to be the most recently registered patients or living in the least deprived areas of North East London. Next, please. So overall, we've presented a highly accurate and transparently validated address matching algorithm, and we've measured the biases in its results. So the next steps are to continue collaborating with Wales to apply this to care home address registers, and this will support evaluating COVID-19 risk and outcomes in care home residents. Thank you.
Hello everyone, I'm delighted to welcome next Claire Hasty from the University of Glasgow, who's going to be talking about vitamin D concentration and COVID-19. Over to you, Claire.
Thanks, Lucy. Good afternoon, everyone. So in the hunt for risk factors and by extension interventions for COVID-19, there has been a lot of attention in the media and to a lesser extent within the scientific community as to whether there's any link between vitamin D levels in the blood and COVID-19 risk. Proponents of a link, who believe that lower vitamin D in the blood leads to increased risk of COVID-19, cite some early studies. However, these studies are either ecological, at an individual level, but unable to fully adjust for potential confounding variables, or they've measured vitamin D in patients who are already hospitalised with COVID-19, which introduces the possibility of reverse causation. And this limited evidence has been overstated in the press and reported with varying degrees of thoroughness and accuracy. If there is a causal link between vitamin D and COVID-19 risk, then vitamin D supplementation would present an appealing, low-risk, cheap intervention to reduce that risk. But is vitamin D a silver bullet in the fight against COVID-19? Not according to our analysis of UK Biobank data. We linked blood vitamin D concentration at baseline in around about 350,000 UK Biobank participants to COVID-19 test results provided by Public Health England. At the time of our analysis, there were 449 confirmed COVID-19 infections within the UK Biobank population. We found that although there was an inverse association between blood vitamin D concentration and COVID-19 risk univariably, this association disappeared once we adjusted for potential confounding variables. Importantly, some of these variables that we observed to increase COVID-19, to be associated with increased COVID-19 risk, such as being overweight or obese, or being of lower socioeconomic status, are also associated with lower vitamin D in the blood. This indicates that previous studies may have found positive associations due to inadequate adjustment for confounding variables. One of the reasons for the interest in a potential link between vitamin D and COVID-19 is the belief that it may in part explain the disproportionate effects of COVID-19 on ethnic minority individuals. Consistent with other studies, we did observe increased risk in South Asian and Black participants in UK Biobank. However, this was not, this association was not amended once we adjusted for vitamin D, indicating that the higher risk observed in these individuals is not due to their lower vitamin D status. We await results from randomized clinical trials, but at the moment, our research is an important contribution to the balance of evidence in this area.
Thank you very much. And we will move on to Alvina Lay, sorry about that, at UCL.
Thank you, and good afternoon, everyone. I'm Alvina Lay, and today I'm going to talk about our latest work on modeling excess deaths caused by the COVID-19 pandemic in patients with cancer and multimorbidity. Let's start with the patient. In panel 1, I illustrate a 50-year-old woman with breast cancer, hypertension, and obesity. She asked, "What is my risk of dying in the COVID-19 pandemic?" Her carer might ask, "Should she be staying at home and remain shielded?" Her doctor might ask, "How can I optimize her medical care during the emergency?" In panel 2, using hospital data from multiple centers in the UK, we show that urgent referrals for early cancer diagnosis and chemotherapy attendance are drastically declining during the pandemic and have recovered slightly since lockdown and the easing of lockdown. This suggests that cancer patients are affected by service change, which may contribute to an increase in excess deaths. In panel 3, we estimated both direct and indirect excess deaths for 24 cancer types by assuming a 10% COVID-19 infection rate and that 30% of individuals who are not infected but are indirectly affected by service change and other factors. At a relative risk of 1.5, we estimated over 17,000 total excess deaths in 12 months. In panel 4, our study prompted a question to the Prime Minister, asking how can he ensure that cancer patients are receiving optimal care during the pandemic? Our study also has policy and societal impact. For example, the NHS published a statement urging the public to seek help for cancer symptoms. The Macmillan Cancer Support also emphasized to the public that cancer should not be the forgotten C in the time of the coronavirus pandemic. Thank you very much for your attention.
Okay, so next we have Samuel Lambert from the University of Cambridge, who's going to be talking about the Polygenic Risk Score Catalogue.
Hi there, my name is Sam Lambert and I'm a postdoc at the University of Cambridge and also a visiting postdoctoral fellow at the European Bioinformatics Institute. And so today I'm going to tell you a little bit about my work at the HDR UK Cambridge site to develop the Polygenic Score Catalogue. Many of you might have heard of polygenic scores or polygenic risk scores as they're sometimes known over the past couple of years, as they've become quite a popular tool to predict genetic predisposition to different diseases and traits. And so polygenic scores are typically derived from some sort of large-scale genetic data like a genome-wide association study, and they turn this variant information in these associations and to an individual prediction of disease risk relative to a population. These predictions can have multiple uses in the clinic, and many predictions of disease risk using demographics or disease-specific risk factors can be improved when adding genetic information from polygenic risk scores. And this has been shown for a lot of different diseases, including coronary artery disease, stroke, and multiple cancers. And a lot of companies are already marketing this data to consumers. But there's a lot of differences in how polygenic scores have been developed and evaluated in the literature. And so we sort of have tried to address these questions because they're leading to some confusion about which polygenic scores exist and how well they work and whether you should use them. So we developed the Polygenic Score Catalog, or the PGS catalog for short, to answer these questions. And it's an open database of existing polygenic scores that can be used by researchers and clinicians in diverse applications. Currently, the Polygenic Score Catalog has data from 82 publications, and we're constantly curating more data and also accepting user submissions of scores and polygenic score evaluations. There are 200 polygenic scores in the catalog for 92 diverse traits. And so just to list a few, there's breast cancer, blood lipids, stroke, diabetes, schizophrenia, depression. And on the right, I've shown an example of the information and the rich metadata we display for each polygenic score in the catalog. So here it's information about the trait it predicts, descriptions of the samples and genetic data used to train the score, as well as metrics describing how well the score performs. And so this score is the PRS 313 for breast cancer, developed in Cambridge. Each of the scores in the catalog can be downloaded from their scoring page, but the entire catalog is downloadable and accessible by an API. And even though the scores in the catalog require some information about how well they work and how well they perform, a more complete and directly comparable set of performance metrics would inform questions about which is the best score for any particular application. So for instance, there's 9 different scores for colorectal cancer in the catalog. And we undertook a small benchmarking study in the UK Biobank where we took each of those polygenic scores and evaluated their ability to predict colorectal cancer status in European, African, and South Asian ancestry participants, giving a consistent set of performance metrics for each polygenic, each score for each polygenic trait. And we'll be continuing to do this with other diverse cohorts and all the scores in the catalog. So to summarize, I've presented my work to develop the Polygenic Score Catalog, accessible at pgscatalog.org. And it's an open database of 200 scores that are provided with metadata and available for researchers and clinicians to use.
Thank you very much. Very nice. And we will move on to the next speaker, which is Claire Niedowitz from the University of Glasgow.
So we examined if and how ethnicity and socioeconomic position affected risk of COVID. So this research was done at a time a few months ago when there was actually a lack of evidence on this topic and what might actually explain any differences. So we used data from UK Biobank, which baseline data linked to Public Health England test results for COVID. And this included around 400,000 participants in England. So we know UK Biobank is not representative of the population, but it does have excellent data on self-reported ethnicity, which often NHS data doesn't have. And it also has data on a range of different risk factors. So the outcomes we looked at were the risk of being tested, testing positive in hospital, reflecting more severe disease, and testing positive amongst those who were tested. And our key variables were ethnicity, socioeconomic deprivation, and education level. And we looked at a range of potential explanatory variables, including country of birth, baseline health, household size, occupation, and a range of lifestyle factors such as smoking and alcohol. So our key results were that Black people, including African and Caribbean participants, were at 3 times increased risk compared to white participants. South Asian people, including particularly Pakistani people, were at 2 times increased risk. And accounting for ethnicity, we found that education and deprivation were associated with a 2 times increased risk as well. And the increasing risk, you can see from the graph, it's not just due to ethnic minorities being tested more. So you can see the size of the effect increases across the more kind of severe outcome. And accounting for a range of factors, explain some of the risk, excess risk, but not all of it. So to conclude, ethnic minorities and socioeconomic disadvantaged people are at an increased risk of COVID-19. These inequalities reflect long-standing societal inequalities. So health inequalities are obviously nothing new, but we need to think about what we're not capturing in the data at present. So things like our ethnic minorities placed at an unequally high risk situations. So there's anecdotal evidence that transport workers, for example, from ethnic minority backgrounds might be placed at increased risk. Do they have equal access to PPE? Are they able to access healthcare equally? And also, is it institutional racism at play, and what we can all do to eliminate this? So our paper contributes to the growing evidence that ethnic minorities are at increased risk of COVID, and we also know that they're also at increased risk of death. So now is the time to act on this evidence. So our paper is now published in BMC Medicine, if you want to read further, and it's already made an impact by being discussed by the SAGE committee. Thanks for listening.
Thank you, Claire. And next we have Joran Posner from Imperial College London, who's going to be talking about monitoring diet more accurately to aid living in a post-COVID society. Over to you, Joran.
Thank you very much for inviting me to speak today, Lucy. So after coming out of the hospital, the Prime Minister recently made a statement to declare a war on fat. And this is likely to sprout some new and updated public health guidance about what people should and shouldn't be eating to achieve a healthy waist and diet. So despite doing my daily PE with Joe sessions, my body has been storing some excess energy, so to say, even though I try to maintain the same type of diet as I did before the lockdown, while sitting quite close to the fridge over here. So my talk focuses on how we might better understand what people are really eating and what is happening inside by analyzing chemical compounds excreted in urine. So we've used data from around 2,000 individuals whose dietary habits were closely monitored. They had their blood pressure and anthropometrics measured, and they also gave 24-hour urine samples. What we did is we measured small molecules excreted in urine with protein NMR spectroscopy, and we investigate which of these metabolites associated with the intake of different nutrients. From that work, we identified 46 metabolites that relate to 67 different types of nutrients, and therefore these metabolites can also tell us about different dietary patterns. So the within-person differences in urinary metabolite excretion were actually smaller than those from reported nutrients. So hence the metabolites were actually more stable over time as a measurement. And these metabolites are indicative of different types of processes that happen in the body. They're both related to our genes and also the microbiome. So they give this bit of extra information in addition to reflecting the dietary patterns. So these 46 metabolites, they can actually predict with good accuracy the eating habits of these individuals, and the eating habits themselves were assessed using common use dietary scores. However, there is quite often misreporting of data and misreporting of food data, and this especially might be problematic for making inferences from small to medium-sized studies. Therefore, what we've done is we conducted a clinical trial where participants got 4 different diets that were completely controlled with different adherences to healthy eating guidelines. And the developed dietary score, where higher is better, is based only on urinary data and predicted well the established dietary scores such as DASH. And it also gave new interesting insights of inter-individual differences relating to even energy loss via the urine. We then tested our score in another clinical trial focusing on weight loss, and we found the dietary metabolite score inversely associated with blood glucose and directly with HDL cholesterol. And at the moment, we are currently testing this for the clinical management of people at risk of cardiovascular disease by using it to give them personalized dietary advice. While at the same time, we can see how they respond at the individual level to different diets and what they are really eating. And as part of this, we also recently took part in a TV show where 10 members of the public tried to eat healthier and also lose weight. And we used our score to track how they were doing. So what we want to see in the future is that we hope that our work can understand better what approach for dieting and other things works for different people when they try to lose weight. So what ultimately they can be on their highway to health. So that concludes this. If people are very interested, I will make one small note and I can spend 30 seconds on that, so to say. The 2 publications that I talked to, you can find at the bottom of the slide. They are actually switched. So one is likely to come out tomorrow as we are, and the first one is actually going to come out next week on the 22nd of June at 4 p.m. London time and 11 a.m. US Eastern time. So thank you very much for that.
That's fantastic. So a huge thank you to all of our speakers in this lightning session. I should let you know that people were selected as part of a really competitive process. It's fantastic to see the breadth of work being carried out and the progress being made. These are all early career researchers, so fantastic work. Please remember to vote on which talk you found the most thought-provoking. So I think the poll is currently up on your screen just now. Prizes will be awarded during the plenary session at the end, so come back and see who's the winner. Once you've done that, can I ask you to please look at your virtual delegate pack again so that you can get the links to the next sessions, which will be starting promptly at 13:50. I think the 2 breakout sessions is one on better care and one on public health. And we look forward to seeing you after lunch at 10 to 2. Thank you.